Chancellor at UAMS, University of Arkansas for Medical Sciences. Thank you for being here, Doctor.
Lieutenant Governor, thank you so much for having this conversation about something that everybody wants to hear more about.
Well, thank you. Well, we got a lot of questions last week, and I want to explain so no one thinks I'm being rude, but I'm going to be getting questions text to me here on my phone, so I'll be checking that occasionally. So if you're listening and you've got some questions, just please post them there on Facebook, and I'm going to have a staff member here text me those questions, and I'll be checking them occasionally, and we'll get to that. But let me jump right in, if I could, Cam, Dr. Patterson. First of all, as a practical matter, I want to just sort of go through some of the guidance that we've been given by the governor and you and Dr. Smith at the Department of Health, some of the basic guidelines so that we know what we need to do to keep ourselves safe and our loved ones safe. Just to recap, the things that I always remind people of: wash your hands frequently, keep a safe distance from others, at least 6 feet. At least 6 feet. Don't gather in groups, and if you have a compromised immune system or respiratory system, or you're a senior adult, try to stay at home if at all possible.
Yeah, and avoid unnecessary travel.
Avoid unnecessary travel. There's another one. So those have been pretty constant, but tonight I want to talk about some of the discussions that I've seen in the press, both on television and in the print media, and just talk about whether we need to amend some of that guidance. So the first thing I want to talk about is the news that came out today that indicated that the virus can be spread by someone breathing. Initially, we heard coughing, wheezing, sneezing, that sort of thing, and we heard a lot about these droplets that may have the virus in it. Today, we heard that someone could be talking, someone could be simply breathing, and put that infection in the air. Can you, I assume you've seen that, and could you talk a little bit about that risk?
Yeah, absolutely. So first of all, thanks for the invitation to be here and to have a chance to talk to people about this.
Sure, thanks for coming.
Applaud you doing this. For the most part, we think about respiratory pathogens, and those are big words, but the colds and flus that we typically have as being infectious when you're symptomatic. You know, when you're coughing, when you're hacking stuff up, when you're feverish, and that does not seem to apply to COVID-19. We already knew that people were able to transmit the virus before they were symptomatic, even if they never became symptomatic.
So even if they don't know that they have it,
right,
but they could be a carrier of it,
right,
they can still pass it to someone.
Exactly.
And that's where a lot of the danger lies with the elderly, for example. You may not know you have it, right?
For sure. And so it's not really a surprise to me that we are now talking about just simple transmission without coughing and hacking. We kind of already knew that, but now it's been documented. It just goes to show why this has become such a dramatic, overwhelming pandemic in a short period of time, because most of us know in our heart and soul that you don't go to church if you've got a big cough, you don't go to church if you've got a fever, you don't go to work if you really don't feel well, and this virus is able to transmit even when those warning signals haven't turned on yet.
So that sort of leads me to the next topic, which is the topic of the mask.
Yeah.
So you hear a lot about the masks that are the sort of the more professional, expensive masks. I think they're N95 masks, right?
Right. So the N95 masks are the masks that healthcare professionals use when they are being exposed to somebody who might actively be secreting large droplets that are dangerous. So, if you
is that a standard surgical mask?
No, it's more than a surgical mask. This is a containment mask.
Right, right.
So
it is more form-fitting, it's more expensive, it's more robust.
Yeah, so just to put it in perspective, the way you can tell an N95 mask works is if you're sitting next to somebody who's eating a piece of pizza, you should not be able to smell the pizza.
Okay, so it's more than, I've got a sample here, it's more than just sort of these thin paper masks that you see people wearing.
Right.
You know, a lot of times before this pandemic, particularly in Asian countries, Japan and elsewhere, you see people as a matter of culture
Right.
wearing these. I visited Japan last year, and it was interesting. I even Googled to read a little bit about the culture, and people will wear these when they're sick,
Right.
as a courtesy to others to make sure they're not transferring that.
But that's the way that they work, and I
Yeah.
think it's important for people to understand that that's a surgical mask. It's not designed to protect the surgeon. It's designed to protect the patient.
Okay.
And when you are going around wearing that mask in public, because of cultural reasons, or now there's some guidance that maybe we should do that, it does not protect you.
Okay.
There's no data that it protects you. It protects other people in case you are secreting viruses that they might interact with.
But if droplets, just arguing this point for a second, if droplets are in the air and you're wearing this, it would seem to me you're less likely to inhale it.
There's no data to
No
support
data
that.
to indicate that, because it's so small and
Well,
because these are so porous.
They're so porous. So that's designed to contain your secretions.
If you call
to
for something
protect
in surgery,
other people
I got
from
you.
you. So
Gotcha.
that's what they do.
Gotcha. So there has been, in the last day or so, in fact, I saw it at the White House briefing today, there's been some discussion about whether people should wear masks going to the grocery store. And I think a lot of the concern early on was people who aren't on the front lines, for example, like our amazing healthcare workers, many of which work for you,
Yeah.
many of whom work for you. People who aren't on the front lines might be using masks that people on the front lines need, particularly the N95 mask. Is that still a concern? Is that a reason why you think there's still not this recommendation nationally for everybody to be wearing masks? Is that still part of it?
That's a big part of it. So think about UAMS. We've got thousands of people coming and going every day, 10,000 employees, many patients, many family members, many people who are coming and going for a variety of reasons. If we gave each of them one of those masks when they walked in, we wouldn't have masks for frontline caregivers who need them.
So supply is a big
Supply's a big
part
issue.
of it.
Yep.
To your earlier point, even though the data may not be there to show that wearing that is protecting you, if there's a chance that lots of us might have it and not know it, it may be protecting others because we don't know we have it and we're coughing into or we may not even be coughing, we're talking into
right. So what you're talking about is the prevalence of the virus and how likely an intervention like that will be beneficial.
Yeah.
If you're in New York City, where you've got literally tens and tens and tens of thousands of individuals who are infected, that's probably beneficial. In a state where we probably have fewer than 1,000 people who are infected, it may do more harm than good. And I think that's where
so it's a balance because of supply and what. So to be clear, so the guidance right now from healthcare experts in this state is not that everybody needs to go out and buy a bunch of masks and wear them all the time.
That's right.
Yeah.
If you feel better about, if you have a mask, you feel better about walking around with it on, you've got the freedom to do that. That's the state that we live in.
Gotcha. Very, very good. So let's talk a little bit. First of all, let me see if I've got, okay, Karen on Facebook. Thank you, Karen, for this question. She says, she asked this question: if you have COVID-19, how long after you recover can you return to work? When or should you return to work? When is it safe?
Yep. So Karen, that's
Thank you, Karen.
That's a great question. The guidance right now is that you shouldn't return to work until you are asymptomatic and afebrile for at least 3 days.
Okay. What's the second word you use there?
Asymptomatic and afebrile, without a fever.
Afebrile. Okay.
Yep.
So no fever, no coughing,
right?
No wheezing.
But the fact of the matter is that I think that since we're not overwhelmed, you probably shouldn't return to work until you checked with your healthcare provider.
Yep. So it's always a good fallback. Check with your healthcare provider. If you think we went over this last time. If you think you might have a cold or flu or coronavirus, you're not sure. Don't go to the emergency room. Call your healthcare provider. Stay at home. Call your healthcare provider. Follow their instructions. Correct?
Exactly, and I'm not just putting in a plug. There are a number of phone lines that are available to receive calls about these things. We've got one at UAMS. Arkansas Children's Hospital has one specifically devoted to children's issues, and UAMS Health Now is an online face-to-face portal where you can have a conversation with a healthcare professional to ask questions just like these.
Gotcha. Perfect.
For free.
And I want to emphasize, if we go to a wide shot here, we are sitting significant distance from each other, and we are following all the guidelines. I'm told we're sitting precisely 6 feet from each other, and because I'm leaning back as I like to do, I'm probably more than 6 feet. So now I want to talk a little bit about some of the potential treatments and therapy that I've seen on television. It was in the paper yesterday. It's been in numerous newspapers. Even the New York Times covered it. I think the president mentioned one of the drugs a day or two ago, and I want to dig into to that a little bit. And I want to start by just holding this up. So this is a story that was in the New York Times on April 1st about hydroxychloroquine, which I know you're quite familiar. And the reason I pulled this, first of all, the headline is Malaria Drug Helps Virus Patients Improve in Small Study. A group of moderately ill people were given hydroxychloroquine, which appeared to ease their symptoms quickly, but more research is needed. And one of the things that struck me is there was a quote in here by a professor at Vanderbilt who is an infectious disease expert there, Dr. William Schaffner, quote, this study, or this drug, is going to send a ripple of excitement out through the treating community. And then he says, I think it will reinforce the inclination of many people across the country who are not in a position to enter their patients into clinical trials, but have already begun using hydroxychloroquine, quote, he said. Can you talk a little about to a doctor, what is hydroxychloroquine known for, and what's your view of the use of hydroxychloroquine to treat this? Can you talk a little bit about that, and then we'll dig a little more into this, because it's in the news really big today and has been. I think this is what President Trump mentioned, I think, a couple of days ago.
Sure. So hydroxychloroquine is a derivative of an older drug called chloroquine, which was one of the very first drugs that we used to treat malaria. And hydroxychloroquine was a second-generation anti-malarial drug for malaria, and that's when I was growing up as a doctor, that's what we used it for. And it can still be used for that, although there are other therapies now for malaria. But over time, we learned that hydroxychloroquine has anti-inflammatory effects.
Okay.
And that's important when we think about something like COVID-19 infection. And so the main use for hydroxychloroquine now in the United States, we call it Plaquenil is the brand name, is not for malaria. We don't see that many patients with malaria in the U.S. anymore. It's for lupus and diseases like lupus, and it's used for its anti-inflammatory activities. So
would someone take this during flare-ups or prophylactically all the time?
Both.
Okay.
Yeah. But it's one of the drugs that a patient with lupus would have on their regular panel of medicines that they're routinely taking. Then the dose might go up if there's a flare and then come back down. And so the thought process behind using this for a virus like COVID-19 isn't that the malaria and the virus are similar. They're completely dissimilar. Mm-hmm. It's that this is an inflammatory process. We know that the lungs get inflamed. That's why people die. And so an anti-inflammatory drug like hydroxychloroquine might be beneficial.
Okay.
Now, the mainstay of therapy for COVID-19 right now is, number one, don't get infected.
Right.
And then number two, it's supportive therapy. But if there are other things that we can bring to the table for intensely ill patients, you bet we want to know about them.
So can you talk a little bit about the safety of hydroxychloroquine, just as a general matter? If people are routinely taking this for lupus and other rheumatological problems, mm-hmm. Can you talk a little bit, what kind of side effects, is there a safety concern? Why the reluctance? Mm-hmm. Is there a toxicity issue?
Well, every medicine that you take is, has some toxicity. And, you especially want to be mindful of that in someone who is critically ill, right? Mm. Just a little bit can tip you over into a bad situation. So we don't want to be cavalier about, well, this might work. I can think of a lot of things that might work for a COVID-19 patient. But a drug that, has a long-standing record of being used, that's a good thing. We're not talking about years and years of therapy with hydroxychloroquine.
Maybe a week or two.
Maybe a week or two or something like that. So, so there are reasons to be readily accepting of the idea that, look, if this gets you a 90% benefit, that's great. But even if this gets you a 20 or 30% benefit in terms of outcomes with a good safety signal, that's still an impressive result.
So it's still something being looked at, and some people are using it already. Some people,
people are using it, and the thing that concerns healthcare providers like me about this is, let's make sure that we don't do this in a way that takes a medicine that a lupus patient who we know needs this and desperately needs this, let's make sure we don't take that medicine away from them.
Yeah, so now you're getting to the issue, and I won't belabor this, but I do want to explore it. I'll tell you what, let me see if there are any questions here before, we do have one, great. I'm just guessing, and here they are, okay. So Jackie on Facebook, she says, can you explain why we're reacting differently to this virus than we do the flu? And a follow-up to that, or related to that, and this is a paraphrase, we've never closed businesses and shut down the economy over the flu. Why are we doing this now?
Yeah, so that's a great question, and a question I get all the time.
Thank you, Jackie.
So Kathy, the three reasons why this is different. Number one is that this is more contagious than influenza is by several folds. So, the probability that if you or I had this, that we would transmit this to one another is much higher. And we just talked about the issue that this is transmissible when you're asymptomatic, which is
the flu, and this is a question.
Yeah.
The flu generally is not transmitted when you're asymptomatic.
That's correct.
So, so that's a big distinction, right? So if you're not coughing, feeling fever, etc. with the flu, you generally aren't spreading it.
Right.
With this,
You
you don't even know you have it, you're spreading it.
Right. So that's
Okay,
that's one
number
issue.
one.
So number two is the fact that this is much more lethal than influenza.
I think I saw
is.
10 times.
It's about 10 times.
It varies depending on what the numbers are.
It's about 10 times. And you know, while there are exceptions, it's really rare to die of influenza if you're not already pretty sick.
Right.
Whereas with COVID-19, a friend of mine who's 52 years old just passed away yesterday. No other medical issues, you know, so this, you know, has an impact that
Was this a healthcare provider?
It was, yeah, a healthcare provider in New York. So you know, this impacts people who, you know, you wouldn't otherwise would suspect would be susceptible. Third reason why this is a bigger deal, and this is important to understand, is that we've all got some herd immunity to influenza. We've all had it in the past, and while you can get it year after year, the fact that we've been exposed to it protects us a little bit, at least, every year, and then we've got vaccines. We don't have any of that for COVID-19.
We have Theraflu, we have both prophylactic protection, such as a vaccine, and the herd immunity, right, that you're talking about. And then if you do get it, we have therapy that can shorten the flu. So we know a lot more about the flu, is what you're saying.
We do.
And we're much better equipped.
And you know, every year, you know, influenza comes through in winter months, but every year we don't have 100,000 or 200,000 people who die of influenza.
Right, right. Very good. Let me see if. So that was from Jackie. Thank you, Jackie, for that question. Now I want to go back to something you raised, and I just want to sort of close the loop on this hydroxychloroquine. You talked about the potential shortage or the specter, the threat of not having enough hydroxychloroquine if we begin to use it for the coronavirus. What about the people who use it for lupus and other rheumatological problems?
It's a big concern.
And I got a letter on that today, actually, and it was got a letter from the American College of Rheumatology and 52 other organizations. I guess they sent it to the governor, to me, the insurance administrator, and basically they sent a letter saying, we see that hydroxychloroquine is being used now to combat coronavirus, and we're concerned that we may not have enough supply to address the needs of people with rheumatological problems. So they are weighing in on this, and I think we will hear a lot more in the coming days of how many doses of hydrochloroquine we have access to, and that sort of thing. Let me ask you this: in the state, we're a rural state in large part, but we also have some growing metropolitan and areas and cities. Jonesboro and our hearts and minds and thoughts and prayers with the folks in Jonesboro. They not only battling this, but they had that horrible tornado. One
of our residents lost his house.
One of your UAMS residents lost. I did not know that. It just it's so it was just horrible. So you've got Jonesboro that's growing. You got Fort Smith that's growing. El Dorado, Northwest Arkansas is obviously booming, and of course Little Rock is by far the largest city. So we are known as a rural state, but we have some significant population centers as well. Pine Bluff. Can you talk a little bit as you sort of survey the state? I mean, UAMS is in Little Rock, but you have clinics around the state.
We're a statewide entity. We're in 73 out of 75 counties of the state.
Yeah, 72 out of 75, right? So you're based here. A lot of people think of you as Little Rock, but you really are everywhere in the state. And I know that we've talked about this before. You've been really big advocate for telemedicine and also providing a lot of healthcare out in the rural parts of the state that traditionally may not have had access to some of the services and expertise. If you could talk a little bit, looking at the state, could you talk a little bit about the differences you've seen in terms of the total number that we have? At least we don't know the total number, but we know how many we've tested that have been infected. And just knowing, looking at that number, which is now, what, 643?
Yep.
Okay, thinking about those 643 and how they're sort of distributed around the state, what differences are you seeing? I know we had a pocket in Cleburne County that was sort of unusual that we think had a lot to do with people gathered together. Can you comment about the rural versus urban and maybe where most of these are located and what trends you're seeing?
Yeah. Well, you know, I think you're touching on an interesting issue. You know, if you look at the maps, you know, there are areas that are a little bit surprising that there are clusters. You mentioned Cleveland County, but you know, the big clusters are Northwest Arkansas, Pulaski County. Now, part of that is that that's where the people are.
Right.
But part of that is that's where the tests are being done.
That's right.
So, you know, if we're not going out into Ashley County and Chico, and
we just don't know really what we don't know.
Then we don't know, and we've got to do a better job of that. I'll tell you, today, our UAMS van went out to Helena, Phillips County, and did several hundred screens for people who are concerned about COVID-19. We're going to go to Texarkana.
We don't know, of course, at this point, how many of those are positive,
no,
if any.
We just screened them, but people showed up and they had symptoms and they passed, you know, we don't just test everybody.
Yeah.
You've got to
have a fever, show some sort of.
Right. So, you know, we did a whole bunch of tests. We're going to go to other parts of the state to do that. We've got to go to these communities and help them out. Some of these communities have hospitals that are already working on this, but some of them don't. And you know this.
Yeah.
You deal with this every day. You've been a big advocate for this. You know, we can't leave you behind just because you've got a small population in your county.
Right. Right. Well, that's excellent that you're going out and doing that. And a lot of the low numbers in some of these counties may be because we just don't know.
We just don't know.
But I think it's fair to say that the threat is a threat not only for all of our country, but every county in this state.
Right. Well, you know, and you know, look at Georgia, Albany, Georgia, which is a very small town, has had a big, devastating outbreak. Right. And you know, neither one of us want that to happen here in Arkansas. Yeah. Which particularly I mean, when you have that sort of outbreak in a smaller place, and Albany's a lot bigger than some of our towns, but it's no Atlanta. When you have an outbreak in a rural community, they don't have the capability in terms of the infrastructure. You don't have the protective equipment. You don't necessarily have the intensive care unit opportunities, and you know, it's a potential for a bad situation. Well, I appreciate what y'all are doing on that. The other thing I wanted to ask you about that, I saw the governor's press conference today where he had the chart showing us where we are versus where we could be if things were worse. Yep. And it looks like that you don't want to. I know that the incubation period for this is 10 to 15 days, and so we're sort of what we're experiencing today is really what happened 10 to 15 days ago. So I don't want to get ahead of myself. But it does look like the policies that are being implemented have had a positive effect, and that we collectively, following the governor and health professionals' guidance like yours, that we are doing pretty well, relatively speaking. Is that fair to say? It is. Based on where it could be? It is. So, you know, if you look at, you know, the state of Florida, our infections started on almost exactly the same day, and they've had 10 times more infections in Florida than we have. And
now, is that adjusted for population?
It's partially adjusted for population. So
Yeah.
I think what has happened is leadership, and
Yeah.
I thank you for for being a part of this message. Have articulated clearly what people need to do. Now, this is going to get worse.
Yeah.
It
Can
is.
you talk a little bit about that?
Well, we're looking at a variety of projections, and I think that we will hit a peak somewhere between late April and mid-May. So there's more pain ahead of us before we start to see this falling off. And we are concerned that our healthcare resources might get overwhelmed. But the thing that is most important to articulate is people need to listen to the message that you're talking about here tonight.
Yeah.
The best thing that you can do, social distancing, don't go out when you don't need to, hand hygiene, no unnecessary travel. And people have listened to that here, and they have not necessarily listened to that message, or they didn't have the opportunity to have that clearly articulated to them.
Well, and I want to mention something on that front. A lot of what people, experts nationally, thought about who could be impacted and who couldn't has been turned out to be wrong.
A lot of it's been wrong.
And for example, the initial wisdom, conventional wisdom, I'd say 3 weeks ago, coming out of the sort of the, and I want to be fair, we collectively in the health community did not know all of what we know now.
Right.
But initially, based on what had happened internationally, which is all we had to go by, the thought was young people rarely get it or won't get it, and they certainly wouldn't die from it. And we've had infants, I think in Chicago, die. A 1-year-old died. The thought was that only the more vulnerable would really be, would face the threat of death, which is not true. The percentage is still low in terms of death across all age groups, relatively speaking, but the bottom line is anyone can get it, and anyone can be affected, and we've had deaths at all the different age range. So it's a dangerous. I think there's been some revision. Some of the things that some of us, like I'm a parent of 3 young children, and we sort of took some comfort in the thought that, well, children can't get it, but that has proven to not necessarily be the case. Is that a fair characterization of the facts?
There's way more that we don't know than we know, and
that's part of the scariness. Yeah.
It's part of the scariness. We cannot take this for granted.
Yeah.
I think if there's one thing to convey to people is that while there's a lot to be proud of about how the state of Arkansas has reacted to the guidance that people who like you who work here in the Capitol have promulgated, there's a lot to be scared about.
Yeah. I would say, we just got a few more minutes here. I want to say that if you really want the best up-to-date information, there's a lot of different sources. And I encourage people to get news and information from multiple sources. But for Arkansans, the governor's press conferences are just absolutely a critical part of your day. And you don't have to watch them when they occur. You can go back and watch them later, recorded. A lot of good information. A lot of rumors out there. It's best, and I'm asked about all kind of rumors all the time. It's best to just listen to the governor and Dr. Smith and you and Dr. Bledsoe, the Surgeon General, and others who are communicating on a daily basis what we need to be doing, what progress we're making. And one of the things I've emphasized all along, regardless of how you feel about your health, your individual behavior directly impacts whether this will be less or more severe, whether it will last longer or shorter.
Right. Well, and I think Governor Hutchinson has said that out loud multiple times. We have personal responsibility involved here.
Yeah. So we don't have much more time, but I do want to get all of the questions. So I'm going to run through these. We've never had a lightning round on this. I don't know what we're going to call these. We're doing them every week. Tim TV, who knows? LG TV, I don't know. I'm calling something. Maybe y'all can tell me on Facebook what we should call this. So John, we heard from Karen and Jackie. Thank you all. John asked or makes a comment. I've heard that warm weather will help kill off the virus. Is that true?
We don't know.
We don't know. We don't know. And there are parts of the world that are warm right now that are dealing with this, right? It's pretty warm here.
It's pretty warm here, and you know what? There's very limited testing in South America, so we just don't know.
We don't know. We don't know. There are different views on that. Eric on Facebook, Tim, would you have Dr. Patterson share his knowledge of a potential antibody test? Now, I think this is what I heard about on television today, where you could, even if you don't have symptoms, you could take this antibody test and they could maybe tell if you did have it?
Well, yeah, so the test that we do now, the swab, the thing that they stick in your nose, that tells if the virus is right there in your nose at that time. Usually we're testing for the DNA of the virus that detects that. The antibody detects the body's response, the reaction, and that would tell you if you've had it in the past, and those tests are coming.
Gotcha. They're coming. I saw something on that today on television. Lastly, Jennifer on Facebook, and thank you, Eric, for that. All these questions have been
good,
fabulous. Really, and we're getting a lot more this week than even last week. Jennifer on Facebook, what can you tell us about the people that need ventilators? Are they mostly elderly, or are they mostly people with health problems, or does it vary? You have a 52-year-old friend who's a doctor in New York who I assume before he passed he was on a ventilator, wasn't he?
He was. There, I've seen 20-year-olds.
20-year-olds. Okay, so anybody that is stricken in a severe way could end up on a ventilator.
This virus attacks your lungs, and it attacks it bad.
Gotcha. Let me see if there's one more thing I wanted to ask, and this is particularly important for healthcare workers. So, and I'd never really heard this before about any sort of virus, but I heard I think I may have even read, I think I read it today, that there was some thought that healthcare workers are being severely stricken because they are exposed multiple times to the virus. Can it really, not that they're getting it because they're exposed multiple times, that makes sense, but is there really, can you really have a more severe bout with it because you were exposed multiple times versus one time?
It's all about the protective equipment. There are where's the hottest zone?
Yeah.
Italy right now, right? There are hospitals in Italy that have had 0 infections in healthcare professionals. So it's about making sure that you keep your workers safe, and that's why the personal protective equipment that UAMS is airlifting from China to provide to the people who work in healthcare across the state is so important. It's keeping people safe.
So absolutely, and the healthcare workers and everybody else helping out on this are absolute heroes. They are truly on the front lines of a life or death situation. So just to be clear, if someone is exposed multiple times to a virus, is there potentially a more severe outcome than one time?
No.
There's no connection between the repeated exposure that you know of.
The only connection is if you don't have great equipment, then the more you're exposed, the more likely your equipment is to lead to an infection. But the key.
But once you have it, you can't say that because someone got it numerous times that it's any worse than if you got it one time.
No.
Right. Okay.
It's just a bad virus.
Yeah, because there was something to that effect that that if you were exposed to it and caught it basically multiple times, it was somehow more severe. And I hadn't seen that anywhere else, but I'm glad you've clarified that. So the critical need is just protect.
Yeah, it's like a tank with good armor. If you got a tank with good armor,
yeah,
you're going to be okay. If you got a tank with bad armor and somebody shoots at you 10 times, one time might get through.
Gotcha. So just want to make sure we don't have any more. We have one more we're going to take, and that's the last one I've gotten. Yeah. So Chris on Facebook, is behavioral health considered an essential service? Christopher, sorry. Well, Christopher, I want to just politically or from a policy standpoint mention that, and then obviously would love to hear what the doctor thinks. The states that are in what's called a lockdown or a shutdown or a shelter in place, they're the ones, and there's a bunch of different ones, they're the ones that are distinguishing between what's essential and what's not essential. And they have to do that because all businesses aren't allowed to open. Or most businesses aren't allowed to open. So they distinguish. You're essential or you're not essential. That's not where we are in the state. And the governor talked about that quite a bit today. And talked about the success that the numbers show that we're having here with his approach. But this, hey, I'm essential, I want to continue to work, and I want to continue to stay open, or these people are not essential. That sort of discussion is for the states where there's a shutdown or a shelter in place, and not, at least not to my knowledge. And again, I don't know everything that's going on, but not to my knowledge, I haven't heard anyone pursuing that policy in this state. But I will say, just as a matter of my opinion, of course, behavioral health is very important. Critical.
I would actually flip it around and say, there are, having access to behavioral health services is important all the time.
All the time.
But
particularly now.
But the people who are most vulnerable are the people who have behavioral health challenges. And if we are not looking out for them even more now, to make sure that, look, if you have a behavioral comorbidity, you're homeless, and you have COVID-19, and you go back and you don't have a place to shelter, you don't have anybody to counsel with, you're just going to make it worse for yourself and for everybody else.
You're going to be less likely to follow guidance, less likely to be healthy.
This is the time to double down.
Yeah. So I think, Christopher, the short answer on that is behavioral health is always important. If you're talking essential, non-essential in the policy, political shutdown world, that's for states that have done that. That's not what we've done here. Obviously, that's up to the governor, but our policy now is not that. If you're just talking generally, do I think it's essential? I think I've made it clear, and I think Dr. Patterson's made it clear, behavioral health is critically important, particularly making sure people who deal with those challenges get the help they need in the current situation so that they're more healthy in the other ways and following the guidance and what have you. I think we got all the questions off Facebook. I didn't want to leave anybody. We went a little long tonight. Thank you all so very much for joining us. Let me mention a couple of things. This is not just a healthcare crisis. This is a economic crisis. It's impacting a lot of people, families and businesses economically. And so there are some resources the federal government, state government have made available. You can go directly to ArkansasEDC.com. Arkansas Echo Delta Charlie for the military, ArkansasEDC.com. There's a lot of resources there, federal and state, to help people economically. It talks about the loans and the different programs for families and businesses. Also, you can go to my website. It's ltgovernor.arkansas.gov, and there's all sorts of, there it is right there on the screen. Also, if you just click on that, what you need to know, coronavirus, all sorts of resources that link you to the governor's, some of the governor's information, the Arkansas Department of Health, Arkansas Economic Development Commission, whose website I just mentioned, UAMS's website, I believe, is on there. If it's not, it better be on there. We will absolutely have it on there. Yep, there it is, right there. Very, very good. So lots of resources there. And of course, you can always call. You can contact me through the website. You can always call our office. We still have one person as a general rule in this office answering the phone, separate from anybody else. So they're staying healthy. But there will be someone answering the phone every day, 501-682-2144. Thank you all for joining us. Thank you, Dr. Cam Patterson. You're a rock star.
Thank you.
We
Thanks
appreciate
for everything that you, Lieutenant Governor, thanks to Governor Hutchinson, the General Assembly, and our federal delegation. The healthcare providers in the state appreciate you very much.
Well, thank you. The healthcare providers are on the front lines doing awesome. The governors do a great job leading on this. What I'm just trying to do as Lieutenant Governor is echo a lot of the messaging so that people know what they need to do to stay safe, so we can get past this and get on to living the free lives that we love here in this beautiful state. God bless you. Stay safe and call if I can help. Thank you all.